the quality of the presentations and the presenters is certainly merits a large group. Our first speaker is Dr. Donald J. Murphy, who currently teaches at George Washington University Medical Center, or George Washington University, and he's assistant professor in the Division of Geriatric Medicine. Dr. Murphy did his medical studies at the University of Colorado Health Sciences Center. Originally, his colleague, Dr. Joanne Lynn, was scheduled to be with us tonight, and because of illness in her family, she wasn't able to join us, and she recommended Dr. Murphy, and I was already familiar with some of his published works in JAMA on do not resuscitate orders, and I was delighted that he was able to come in her stead and make the presentation tonight, and we're just happy you're here, Dr. Murphy.
Thank you, Jerry. This is my first trip to Southern California. I grew up and am still growing up cheering for Notre Dame football and basketball teams, the Denver Broncos, Denver Nuggets, and the Boston Celtics. So I think you can understand why I came to view Southern California as the evil empire. But this conference has changed that perception, and I thank Jerry for the opportunity to be here. Could I have the lights down? Okay. We've pretty much identified the problem. The jailer says management has asked us all to tighten our belts a bit. Even though we in healthcare are feeling very strapped, we have to tighten our belts and we have to look at ourselves. I would like to suggest one possible, not solution, but at least a contribution to the solution, and that is defining feudal therapy. In this audience, I don't think I need to justify why we talk about what we cannot do instead of what we can do. Medical audiences like to hear about what we can do and not so much about what we cannot do. But I think it's essential that we do identify or define feudal care for four basic reasons. Number one, actually the first three have been mentioned before. Number one is that we're in a system where we provide adequate care to the majority, but certainly not to all. We have 30 million uninsured. I don't know if anyone's mentioned the other 30 million who are underinsured, and then there are many more, I don't know how many millions, like myself, who are inadequately insured. 2 weeks ago thought I was insured okay. Last week when I have to take my son in for some tests, I realized that everything happens, whether it's an NMR scan or whatever, has to come out of my pocket because I cannot afford the Cadillac insurance. And I think there are many people like that. I'm sure a lot of your children fall into that category. Number two is that I do agree with Professor Lamb and Dan Callahan that what we do in medicine does impact how well we shelter our homeless, feed the hungry in our society, young and old, educate the illiterate, transport people to medical care, et cetera, et cetera, et cetera. And because of that, we have to look very critically at what we do in medicine. Number three, we need to define feudal care so that we can reduce the amount of unnecessary suffering that we see because of widespread inappropriate care. Some people have talked about states worse than death. Number four is one that doesn't receive a lot of press, but I think it's just as important as well, not quite as important as the other ones, but it is important. We need to take better care of the healthcare providers that take care of us, specifically nurses. Nurses are the ones who provide hands-on care. I've had a couple operations. I don't really remember my physicians that well. I know one of them was a classmate of mine in medical school, but I do remember the nursing care I got. When I end up in an ICU, or when one of my family members ends up in an ICU, I want them to have a nurse who feels good about his or her job, who is enthusiastic about giving compassionate care, who is not burned out from having felt compelled to provide so much inappropriate care. Those are the four main reasons I think we need to get an idea of what feudal care is. I am going to use CPR in the chronically ill elderly as an example of how we can define futile care. And I'm going to suggest 3 models. Before getting into those, I want to set one thing straight. The conclusion from each of these models will be that CPR in nursing homes, I'm going to use nursing homes specifically, is futile care. I will use futile and inappropriate interchangeably, because when you say futile, you get the idea that it never works. We know that it does work sometime, but I will argue that it is definitely inappropriate based on the models. That doesn't mean I don't think we shouldn't be discussing advanced directives and a number of things with older people. We need much more communication, but not necessarily about futile care. The first model is one where we simply set thresholds. We say that if a therapy is not effective in more than X% of the time, we don't do it. It doesn't pass muster. It is ineffective. It is inappropriate. Let's say that as a society, and perhaps later on we can decide how we would set these thresholds, but let's say we determine that 5% is an appropriate threshold for life-sustaining care in the nursing home. Then we decide if CPR in that setting is effective in more than 5%. We go to the literature and find out. Because the first question we should ask is, how do we know what percentage it's effective in? There's 2 different types of studies we can use to find out if something's going to work. One is a study that looks just at outcomes in CPR. We did a study in Boston looking at the outcomes of 503 elderly patients, and of those, 244 were out of hospital. Out of those 244, 2 left the hospital. Now, this model is assuming that survival to leave the hospital is what constitutes success, not getting the blood pressure back up so they can go into the ICU and die a couple days later, but getting them out of the hospital. 2 out of 244, around 1%. Applebaum and colleagues from Baltimore looked at outcomes in a big facility they have there. Out of 115, 2 made it back to the nursing home. Both of them severely demented. One died 8 days later and the other one something like 8 months later. Another study looked at outcomes in rural Wisconsin. None of their older patients made it. So we could say, based on these studies, it's less than, it's around 1% to 2%. It's less than that threshold we set. We do not do it. Here's the catch, though. There are exceptions. There are people who will beat the odds. There is the woman that Rabbi Feldman told me about who arrested at their nursing home, and she's back there walking. There's a 70-year-old who was from Columbus, this was about 4 years ago that the Boston Globe picked up on, who had asystole in the hospital, asystole, flatline. This man was dead. They attempted resuscitation for 45 minutes and then called it quits. They took him down to the morgue, and as the mortician was putting him in the box, he coughed, okay? Your nursing home, 4 or 5 days later, you're on a couple of new cardiac medications, but in general, you're doing all right. You're doing the same things you did before, and you have no new symptoms. That's 100, all right? The question is, what value on the scale would the 85-year-old demented woman that we talked about before give to not having CPR? What value would she give to palliative care? That is, when she arrests, she's allowed to die. To not having CPR, okay? If this woman said, I would give a value of 0 to not having CPR, she's saying, I want CPR. And I value, I want CPR, all right? If this woman gave a value of -15 to not having CPR, this woman's saying, hey, listen, I don't care if I'm in a persistent vegetative state. I don't care if you torture me in the ICU. I want that over not having a chance at all. All right? If this woman said instead, I would give a value of 50, she's saying, well, I give some positive value to not having CPR, but not a whole lot. I'm kind of in the middle. I kind of want it, kind of don't. If the woman said 100, The woman's saying, I don't want it. I give very high value to not having CPR. I simply don't want it. If she said 125, she would be saying, you know something? You're telling me that here at 100, I'll come back to my nursing home right here. Well, I don't even want that. I'm not depressed. But if I could die right now of a cardiac arrest, that'd be great. I don't want to go into the hospital for 4 days and come back and be like I am right now. I would just as soon leave with sudden death. So I'm going to give very, very, very high value to not having CPR. Okay. If you're with me so far on this, I want you to tell me what most 85-year-olds in that condition would give as their value to not having CPR. Anyone? Where on that scale would the 85-year-old put their value? Not that we really know, because we're not going to know exactly, what the demented patient wants. But if we could, where do you think? Or I'll tell you what, pick an 85-year-old who's with it mentally, but has a number of other chronic illnesses. Where would they put the value on that scale? Anyone?
30.
Okay. Someone says 30. Anyone else?
50.
Someone says 50. Closer to 100. 110. 20. Okay? Bingo. We're going to have a distribution, all right? There are going to be those people who want it no matter what. I've met 4 of them over 300 or 400 patients I've talked with. It's going to go just like this. Most of them are going to be right around 70, 80, and there's going to be a lot over 100. I don't know that. That's my guess based on clinical experience. I would suggest that once we get better at measuring utility assessment, this curve could shift way over here. What do I mean by that? I mean that once the patients really understand this therapy, they're not going to want it. In all deference to Bob Perlman, Jeannie Kaiser-Jones, and my colleagues who have done some research in this area, we're just beginning to understand this. And we have all made mistakes in how we measure utilities. I can say that because we're making a huge mistake in the large study we're doing right now. You know why? We're asking the same question that's been asked over and over. Would you want doctors to revive you if your heart stopped beating? You know what people say to that? Of course. Half the people are going to say, of course. That's what we're going to find in our research. That's what I find clinically. Half of them say, sure, why not? But then, if we start at 0, 100 here, we're down to half. Take that 50% and then tell them what CPR really involves. You drop down. Tell them what the outcomes really are. Tell them that their chance of being severe, having neurological impairment is every bit as good as their, getting back to living their usual life, and that's very small. You drop even more. Tell them what the alternative. Tell them it's sudden death, which is painless, and which ain't a bad way to go when you're 90 years old. Then, tell them what the economic implications are, and you drop even further. Only a few people really want this therapy. Now, I would suggest getting back to the scale. Remember our probability here at 1 or 2. When we have a distribution where 95% or greater are placing their utility for not having the therapy above the probability of it working, that is an inappropriate therapy. What we're saying is that is a therapy that does not work and people do not want. That is medically inappropriate. Now, what about economic inappropriateness? Imagine another scale. Here on this axis, we're measuring probability of benefit again, 0 to 100. Up here, we're measuring marginal cost. That is, the additional dollars in order to save one life. Here's how that scale goes. Over here, where it's highly probable, very low cost. But as you come down here to where it's improbable, costs just skyrocket. Skyrocket. So that when you're talking about a therapy that's only 1% effective, the marginal cost is incredibly high. When we talk about the cost for the one nursing home patient that makes it, we're not talking about just the cost of the crash cart that we use to resuscitate her or the ICU care for that patient. We're talking about the cost of the other 99 people who didn't make it. Because before the arrest, we don't know who's going to make it. We have to treat all 100 so that one can make it. Anyone want to guess what that marginal cost is for CPR in this setting? How much society is paying so that that one woman can go back to the nursing home? Depending on the averages you want to use, it varies anywhere from $225,000 to over $2 million. That's a lot. That's a lot. I would say that no matter what public forum we have, we would decide that that is above the economic appropriateness threshold for that patient. I don't know where that threshold would be, but I think that in this case it is. So we have a therapy that is medically inappropriate and economically inappropriate. That, I would suggest, is futile care, and care that we should not provide as social policy. Okay, to summarize, can we have these lights down up here? Let's see. We'll need these down even more up here because some of the slides are kind of light. We have a society that doesn't know quite what to do with death. Hey, Bob, so how's death been treating you? In our society of plural values, we're not quite sure how to deal with it. There are some things that tie us together, though. One is that we like machines, technology. One robot says to the other, the patient is unaccountably depressed. This is not in the too far distant future, okay? There is clearly a technological imperative in our society. Another thing that binds us together is our fear of litigation. The guy saying, and behind you is your anesthetist, Dr. Haversham, who is his attorney and his insurance agent, and of course the insurance company's attorney, et cetera, et cetera, et cetera. I believe that when we set up our DNR policies and when we resuscitate people like the woman I'm talking about, we're not doing this out of respect for patient autonomy and sanctity of their life. I think the vast majority of us think about it because of this issue right here. How can we correct this? Well, as I mentioned, research. It's true. We are in the infancy of research in utility measurement and outcome measurement. We do have some good prognostic scoring systems, but we might not even need the prognostic scoring systems, okay? At this end of the clinical spectrum, we also know through research that clinical impression is very good. Here the doctor says, we may already be too late, Mr. Park. Clinicians, believe it or not, can recognize when care is futile, prognostic scoring systems or not. Nevertheless, there will always be some degree of doubt. One says, now wait just a minute here, how are we supposed to know you are the real angel of death? Finally, I want you to look at this slide. Uncle Sam there is saying, and now my able assistant will demonstrate mouth-to-mouth resuscitation. I would like to point out the difference between CPR in this case and the cases we've been talking about. All right? The similarity is that both are very expensive. The differences are two. One, in this case, the hippopotamus, is that what that is? Yeah. The hippopotamus probably wants to be resuscitated. And the patients I'm talking about, they probably don't want to be. And finally, this gentleman up here, the taxpayer, has a much better chance of succeeding than we have in the nursing homes. Thank you.
Well, I think you will agree with me that we've saved some of the best presentations for the end of the conference. Thank you, Dr. Murphy. When I went on sabbatical at the University of Tübingen a few years ago, I was working some in biomedical ethics, and my host there, Dr. Dietrich Rössler, a theologian and also a physician, asked me if I wanted to be another Robert Veatch. I told him that was impossible, but it did illustrate to me the fact that, although I should like to be in some respects, did illustrate to me the fact that Dr. Robert Veatch has been a leader of us all, and not just in this country, but abroad as well. Through his many books, important books like The Theory of Medical Ethics and a host of others, and through articles, way more, I'm sure, than we could ever list this evening, he has influenced us in many ways. With his work at the Hastings Center and now at Georgetown at the Kennedy Institute, he has continued to lead and is known throughout this country for the way that he has brought us to honesty about the questions that we're addressing throughout our conference. So it's with great pleasure that we welcome Professor Veatch.
Thank you. I'm on the governing board of the Washington Regional Transplant Consortium. We're the group that actually makes the decisions about who gets available organs. I'll tell you about a 67-year-old man, a well-to-do president of a mid-sized corporation. He'd had quadruple bypass surgery, but he was still suffering from serious coronary artery insufficiency. Otherwise, he was a robust man, a regular tennis player. Cardiac surgeon told him that transplant was his most plausible option. The Transplant Consortium, as of today, has a flat policy that age 65 is an absolute categorical maximum age for allocating a heart for transplant. How do we know so much about this case? This particular patient also happened to be the member of the Board of Trustees of the hospital where the transplant might have been performed. And he spared no effort trying to convince us that this was a pure policy of age discrimination. It also suggests some of the dangers of appealing to the exception. It seems that the members of the boards of trustees or the patients who happen to be surgeons from the University of Tennessee have a way of getting the attention when it comes to claiming an exceptional case. Tell you about another patient, 92-year-old woman with stroke, arteriosclerotic heart disease, diabetes. She was semi-mobile. She hears that bypass surgery is a possibility. Her physician explains the risks to her, tries to convince her that it's not worth pursuing because of her advanced age and fragileness. The patient weighs the options. She sees all the disadvantages and the risks. She sees the possible advantage. She says, I believe I want it. Should the physician refuse to perform it? Should the physician be prohibited by her insurer from performing it? Or to state the same question in a slightly different manner, should the insurer say, go ahead and perform it if you like, but we as her insurer will not pay? If rationing is inevitable, then should age be used as a criterion? In my full paper for this gathering, I spend considerable effort arguing that rationing in healthcare is inevitable and in fact is a logical necessity in a world where resources are scarce. I guess I'm saying that Wes Robb and maybe Jim Walters too don't have it quite right. Living wills and autonomy can at best eliminate care perceived as useless by the patient or surrogate. That is, where they perceive the benefits not to outweigh the harms. Those issues are suddenly ethically easy. And I have already recommended on a number of occasions that no insurer should pay for care unless there's evidence that a patient or surrogate consented to the treatment. But that still leaves care in which patients perceive that the benefits slightly exceed the risks, the harms, and at the same time that care is very expensive. It's clearly irrational to fund all such care. There's always something else we could do with those resources that would do more good on balance. Autonomy in an insurance framework is an irrational basis for setting limits. It simply cannot work. So in that context, I ask, should age be a factor, and if so, why? In the paper, I look first at some consequential arguments for and against using age. Suggest that the consequentialist argument in favor of using age as a criterion is pretty straightforward. Resources are scarce. Utilitarians say that scarce resources need to be used in the way they'll do the most good. They opt for those allocations that will do the greatest good for the greatest number. This is the ethical position of utilitarianism, the ethical principle of beneficence. If age predicts negatively the amount of good that will come, then it morally must be used according to the utilitarian. Aggregate welfare may have to be sacrificed, individual welfare may have to be sacrificed for the aggregate good of the society. I believe in the end, both Wes Robb and Governor Lamb's arguments were largely utilitarian in character. There are, of course, consequentialist arguments against the use of age. Some critics buy the principle of utilitarianism but reject the moral calculation. They point out the disutilities of an age criterion, that some elderly can be productive citizens, that there will be psychological burdens of anticipating reaching old age without life-sustaining medical care, or there will be psychological and economic burdens on families. But I think it's quite clear that the alternative of not using age has even greater disutility. Some elderly citizens can be productive, but statistically it's quite clear those same resources used on younger people will produce more. There will also be psychological burdens of knowing that you might not get care when you are young because resources are going to be used for the elderly. But there will be real disutilities of using age as a factor, but there is still a strong consequentialist case for using age as a criterion. On consequentialist grounds, using age is probably a good idea. That seems to me to be straightforward. Some ethical systems, however, hold that morality is not just a matter of producing good and avoiding evil. I'm talking about the ethics of Immanuel Kant. I'm talking about the ethics of Judaism and to a large extent Protestant thought as well. I'm talking about the ethics of the rights tradition of liberal political philosophy. Right and wrong is determined in part by features of actions other than the aggregate amount of consequences produced. So I'd like to examine this evening justice as a principle for deciding whether age is relevant to resource allocation. Justice, in fact, is one of these characteristics other than the amount of consequences that may be relevant in deciding whether a health policy is right or wrong. The egalitarian version of the justice principle holds that insofar as we're concerned about justice, practices such as healthcare policies should distribute resources in order to provide opportunities for equality of well-being. What does that mean for using age as a criterion? It seems at first like justice weighs in against using age. Elderly people are, after all, needy medically compared to others. Even if it is not efficient to treat their needs, justice or fairness seems to require that it be done. This then sets up a battle. Consequentialists urging that we use age to promote efficient use of resources, and non-consequentialists wringing their hands, screaming that that is unfair and unjust. But I would suggest to you that there's an interesting new development. Could it be that justice itself requires the use of age as an allocation criterion? In the paper, I look in some detail at two versions of this justice-based argument before going on to build my own. Now, fortunately, you've had substantial exposure to these other two versions, and I will only comment briefly to suggest to you why I think, even though they're on the right track, they ultimately fail. I'm referring to the versions of the defense of the use of age by Daniel Callahan and Norman Daniels. Dan Callahan's version, you've heard described in detail. It essentially is based on a notion of a natural lifespan. Says Callahan, I believe an age-based standard for the determination of life-extending treatment would be legitimate. Let me suggest three problems with the Callahan version of this non-utilitarian defense of an age criterion. First, I think we saw this morning that there is increasing doubt that there is any such thing as a natural lifespan, at least in the human species. Back in 1979, Dan Callahan and I wrote a little notice book where we teased out these arguments. I was arguing against the possibility of a natural lifespan. Dan was arguing in favor. In a way, we rehearsed the argument that now, some 11 years later, we are pursuing so aggressively. There's doubt that there really is such a thing as a natural lifespan and conceptually what that would mean. But my real problems with the Callahan strategy are more practical. It seems to call for some precipitous cessation of claims for services at some age at which the life cycle has been completed. And for the life of me, I can't figure out how you identify what that point is. Different people will probably reach it at different times. Yet we have to have some easily administered, if arbitrary, age. Dan Callahan, one point, suggested age 75. That's back in our 1979 book. More recently, he's been talking about the late 70s or early 80s. Whatever age you pick, it's simply unfair to make a sharp distinction at that cutoff point, say between age 74 and 76. And I believe in practice it simply couldn't be done. Two patients, age 74 and 76, waiting for an ICU bed or a transplant, saying to one, your time is up because you've passed your birthday, saying to the other, perhaps only a few months younger, you're here in time, you get the full treatment, simply will not work. It will be intolerable. Finally, I don't think Dan Callahan can deal with the continuing need for relief of suffering, basic nursing care for cleanliness and dignity and the like. Now, Dan claims that these should continue. But why would we spend money on these treatments when other patients will never reach their full lifespan? If these lives are really over, why do they have claims for even these services? Now, it's intuitively obvious that they do, and we will continue to provide comfort care even for the elderly. But I don't think Callahan's theory can explain why. Word about Norm Daniels. In some ways, a more complicated system, more clearly related to claims of justice. For Daniels, a just system is the intrapersonal allocation that rational, self-interested planners of their own insurance would make behind a veil of ignorance. Now, Daniels claims that we would save a prudent amount for our old age, but no more. This intrapersonal allocation formula makes clear, according to Daniels, that ageism is fundamentally different from other kinds of discrimination that we were talking about this afternoon, based on gender or race. And I think anyone that wants to accuse Daniels of ageism has to do a great deal of work in wrestling with the arguments that he gives. But I see problems with the Daniels account as well. First and foremost, the strategy assumes that all people reach old age. Daniels implies that the prudent thing for us to do would be to give an equal portion to each age-specific need that should be met throughout the lifespan. But that simply does not deal fairly with the child or the young adult with a critical or fatal illness. I might suggest parenthetically that Governor Lamb's system doesn't seem to either. If a majority would spend on infancy or adulthood in proportion to age-specific normal opportunity ranges, Daniels' language, it does not follow from that it is fair to those who will never reach adulthood. Second, it is not obvious that it is only a matter of prudence how resources get allocated at different stages of one's life. Even if it is prudent for people to save for old age, it simply may not be fair or just. So to Daniels, I say prudence is not the relevant criterion. Just like to Dan Callahan, I say the completion of the lifespan is not the relevant criterion. In the paper, I then developed my own justice-based formulation. I use an insurance planning perspective similar to Daniels. I impose a veil of ignorance in order to be fair. But then I ask, is there a fair or just arrangement that those planning their insurance ought to choose? Think back of that 92-year-old woman needing bypass surgery. Imagine we're allocating our health dollars for insurance coverage, and we don't know what our personal desires are. We could incorporate funding for bypass surgery for 92-year-olds, or we could use that funding to pay for needed health care for a child who will never make it to age 92. If we're allocating our health insurance dollars over our lifetimes, would it be fair to spend our money on bypass surgery at age 92, if doing so meant less money for others who will never reach old age? I don't think this is a question that's a matter of prudence, where we can choose any answer that seems attractive to us. I don't think it's a matter of efficiency in serving the common good. I think it's a question of fairness. And justice requires identifying who is worst off and allocating resources accordingly. The real question is, who is really the worst off patient? It's a problem of calculating who is worst off. And here's where I think the real philosophical work needs to be done. I suggest in the paper that there are really two different ways of making that calculation. One I call a slice of time perspective, the other an over a lifetime perspective. Consider two dialysis patients, medically very similar. Both have a 5-year life expectancy of dialyzed. Both will die soon if they're not. One is age 40, the other is age 80. And we're back in the 1960s, there's only one dialysis machine. Furthermore, assume that in their 5 years, both will lead equally useful lives. A utilitarian ought to be indifferent to whether the 40-year-old or the 80-year-old gets the machine. From a slice of time perspective, they are equally needy. But from an over a lifetime perspective, they are radically different in their needs. The 80-year-old has had 40 more good years. On a per lifetime basis, the 40-year-old has had much less opportunity for well-being. He has a much greater claim of egalitarian justice. Now, which perspective is correct? The over a lifetime or the slice of time? In the paper, I developed the argument that for some medical allocations, one perspective is correct, and for other allocations, the other perspective. In particular, I come back to the problem in Dan Callahan's work of how you explain that you provide acute pain medication and basic nursing care for those who've completed their lifespan. I don't think Callahan can account for their intuitions there. I think my theory can. Some needs present themselves anew at each moment in time. They simply can't be accumulated over a lifetime. There's no continuity of personal identity that permits summing up acute severe pain over a lifetime. Imagine two people in the hospital, both in severe pain. One's had a long life of pain, the other has not. I can't imagine arguing that the one who's had a long life of pain has a stronger claim on narcotic analgesia to the one who has not. Acute and severe pain command instantaneous response. The life is detached from the experience of previous years. It's comparable in a way to the response demanded to a child in a well. Utility calculations are wrong. It's not a matter of calculating medical benefits, as Wes Robb suggested. Past lifetime experiences are irrelevant. A slice of time perspective is appropriate because people in acute severe pain are entities separate from their life histories, and each has an equal claim. If we absolutely have to make an allocation, flip a coin. Contrast that, if you will, to measures that extend life indefinitely. In the case of the elderly, adding to an already long life. In these cases, I am convinced that the length of one's history is morally relevant. If you agree, then you will conclude that the over a lifetime perspective is the correct way for determining who is worse off. Has nothing to do with medical benefit, with efficiency or utility or the common good or any of those other criteria. I believe that this is a much more plausible account of the relationship between the 74-year-old and the 76-year-old. There is a prima facie moral claim to life-sustaining technologies that is inversely related to age. Let me go back then, in closing, to the first two cases that I presented. The man at age 67 who needs an organ for a heart transplant. Strange as it may seem, I consider that to be the easier case. It's easier because there already exists a point system for allocating organs. Furthermore, there is an intrinsic scarcity in the hearts that we are to allocate. We can't simply invest more and come up with more human hearts, at least in the short run. We have to give it to one patient among those on the list. I would make use of the existing point system and assign points that are inversely related to age. Specifically, I have proposed to the United Network for Organ Sharing a formula that takes 100 and then subtracts age and multiplies the result by some constant, where the constant is our judgment about the relative importance of age and other factors. In specific terms, I have proposed that the constant equal 0.05, which turns out to make age a consideration not unlike the other considerations presently in the formula. It's unrelated to to whether the lifespan is complete. There is no precipitous drop at some cutoff age. It's unrelated to service to the common good. In this formula, the 74-year-old would get a slight advantage in the point system over the 76-year-old, but they would be so close that it would only function as an absolute tiebreaker when no other consideration differentiated the patients. The concept that I'm working with is one that chronological age is one morally relevant consideration, but there is no precipitous change at any point in the life cycle. And this prima facie use of age works particularly well in organ allocations that already use a point formula. Likewise, I could see it being used as one of the criteria for allocating other intrinsic scarcities like ICU beds or dialysis machines. The prima facie claim is inversely related to age. This brings me to what I think turns out to be a deceptively difficult case, the 92-year-old needing or wanting bypass. Here, the limit is not intrinsic. We could fund more surgeons to do more bypass surgery. Yet some kind of limit must be set at the insurance policy level. I see two options for us, especially if we share an intuition that bypass surgery for a 92-year-old who has a very short life expectancy makes no sense. We could go to an absolute categorical age cutoff, perhaps related to average life expectancy or to some other arbitrary choice we would make as rational planners of our own insurance. We could come up with an age where we will agree for our own insurance policy, bypass surgery will not be funded above some categorical threshold. An alternative would be to establish a quota for the number of procedures our insurance is to fund and fill that quota by taking the youngest patient first until the quota is filled. Our policy should reflect in one way or another that age is one relevant factor. Who gets bypass surgery or other scarce health resources? I thank you and I look forward to the discussion.